Welcome, everyone. My name is Satish Gopal, and I direct the Center for Global Health at the United States National Cancer Institute. We're really grateful to the organizers for allowing us to host this session, which is entitled Equity and Community Engagement in Technology Development, Translation, and Dissemination. Just in the way of background, I think we're all aware that there are major new developments and technologies that are available for cancer prevention and control in low resource settings globally. However, we're also aware that the introduction of new technologies often has a tendency to exacerbate health disparities rather than to mitigate them. And so we're pleased to host this session that will explore, I think, some of the themes that were really brought up already in this morning's session. So our session is intended to consider technology development really with a focus on equity and value, and as much as we can from the perspective of translating and disseminating new technologies to end users with a deep understanding of the local context. Towards this end, we've assembled a cross-sectoral panel that represents academic global oncology, industry, and foundation perspectives on these critical issues to discuss the roles that technologies can play in increasing equity in global cancer control, as well as effective practices for fielding and adopting new and emerging technologies. So I've introduced myself already, and perhaps briefly we can just have our three speakers introduce themselves before we dive into the discussion, and we'll try to cover as much as we can within the relatively brief allocated time of 40 minutes. So Dr. Fadelu, perhaps we can start with you and have you briefly introduce yourself.
Dr. Gopal. So I am Timidaya Fadelu. I'm a medical oncologist at Dana-Farber, and I am a member of our Center for Global Cancer Medicine. I also conduct health services research, specifically in Rwanda and in Haiti, describing some of the global disparities in breast cancer, as well as developing interventions to address some of these disparities. I also want to mention that I was a member of the UICC Young Leaders, the 2015 cohort. So I'll pass it on to the next panelist.
Thanks so much, Deo. Perhaps Dr. Garcia-Gonzalez, you could introduce yourself next.
Yeah, thank you. Thank you for calling me doctor, which I'm not. My name is Pat Garcia-Gonzalez. I'm the head of the Max Foundation, an organization dedicated to accelerating health equity in cancer. And we have been involved with bringing access to cancer treatment to low and middle income countries for the past 20 years. Especially, we have a very large chronic myeloid leukemia program, which I'm happy to talk a little bit more during the session. Thank you so much for inviting me.
And finally, Dr. Andrews, do you want to briefly introduce yourself?
Hi, I'm a women's health specialist and also the Vice President of Medical Affairs for Integrated Diagnostic Solutions at BD, and I oversee our clinical trials. I also have a background in global health.
Great. Well, thanks so much, Pat and Jeff and Deo. Again, with the time being short and a lot to cover, perhaps we can go ahead and dive into this deep dive session. So the first question we wanted to start with, and I'd really appreciate hearing all of your perspectives on this, is if you could talk a little bit about how you believe technology can play a role in increasing equity in global cancer control and increasing access to affordable quality cancer prevention and treatment. So Deo, maybe you can get us started.
Thank you again. So I think a lot of us are familiar with many of the challenges in delivering cancer care in low resource settings. Many themes have been brought up at the, from the earlier sessions earlier this morning. I think sort of drilling down on what some specific challenges are. So challenges around lack of data, challenges around lack of personnel, challenges around some of the social determinants of health factors that patients that sort of influence the ability of patients to to make it through treatment and care. And I think technology certainly has a role in many of these challenges. That's certainly not an exhaustive list of challenges. But I like what Dr. Gawande sort of mentioned, sort of the idea of follow-through innovation, because there are a lot of things that already exist, and there are a lot of things that we know that work, but how do we actually get those things to be implemented in a way that is sustainable in many low resource settings? I think a couple of examples I sort of want to highlight. So, we've talked about the challenges of data and access to data, and there are a variety of electronic systems or electronic medical record systems which already exist, and some have actually been developed specifically for low resource settings. However, uptake of those technologies many times are limited, and really understanding some of the local context and the local needs can influence the way in which people end up utilizing these technologies. So I think I'll stop there and pass it on to somebody else to follow up.
Yeah, no, thanks so much, Deo. Perhaps we could hear from Pat next. Again, the question I think that we're trying to deal with is how technology can play a role in increasing equity in global cancer control. You alluded to your experience with the Max Foundation and dealing with CML, which, obviously you have launched this major international effort to make available this prototypical targeted medicine and many of the technologies that are required to support the diagnosis and monitoring of the deployment of that medicine. So why don't you tell us a little bit about how you believe technology can play a role in increasing equity in global cancer control?
Yeah, thank you. I mean, already this morning, all the talks have been so inspiring, and I was really touched also by Dr. Tedros. I can't help but sit here and think about the fact that the example of access to imatinib from the moment that the FDA approved Gleevec, there was a commitment to make sure that all patients have access in all low and middle income countries. And what I think about that this morning is that in a parallel universe where that commitment had not been made by all the players, we would be sitting here today and we would find more than one reason to rationalize why that's not possible. And so with that, I would just want to remind all of us that, what is possible is whatever we want to be possible, and to inspire all of us to make sure that we think about how to do something and not all the reasons why not to do something. In the same vein, we found ourselves along the way with a really big problem in access to diagnostics for CML. So now we had the treatment available, but we didn't have the diagnosis. And again, we were able to utilize a innovative technology, especially the GeneXpert technology, to sort of leapfrog and bring access to molecular monitoring to many of these countries in the world. And the GeneXpert technology is one of those just sort of really great innovative technologies. It provided us a point of care instrument that was easy to use within a technology, with simple technology in a lab. It's a rapid test, so instead of waiting weeks for a result, the result is given in 90 minutes, deep sensitivity, and most especially, it was being deployed 10 years ago to diagnose drug-resistant TB and other infectious diseases, which meant that these instruments were being put all over Africa and many other low and middle income countries. On top of that, we were able to negotiate preferential pricing. So all the components of a win-win situation. Of course, you can imagine, and we can talk a little bit more later about all the challenges we have had. But that to say that, I think it's up to us to really look for innovation and leapfrog technology to be able to accelerate health equity.
Great. Thanks so much, Pat. Jeff, I want to bring you in here and give you a chance to respond to this as well. In your own work in cervical cancer control, how have technologies been utilized to increase equity in global cancer control effectively?
Thanks, Satish. And I will focus on cervical cancer, and I'll note that the WHO, under the leadership of Dr. Tedros, has announced that it's possible to eliminate cervical cancer. And there are three components to that effort. The first is vaccination, the second is diagnostics, and the third is treatment. So I'll give examples in each where technology can be helpful. In the vaccination work by the National Cancer Institute and the International Agency of Cancer Research has identified that HPV-35 is important for the cause of cervical cancer on the continent of Africa, but it's not currently included in the vaccine. So that's an example of advances in technology that could help with the development of the next version of the vaccine. Under diagnostics, the WHO is recommending primary HPV screening for every country in the world, which is a challenge. One of the ways of reducing cost in an area that we've been quite involved in is using self-sampling, either with a vaginal swab or a urine sample to do the primary HPV screening. At the present time, cytology is challenging for countries around the world. BD has introduced a type of technology called direct-to-slide, which is, I guess you'd call it low-tech, but it gives the same high-quality slide as the more expensive equipment. We're also looking for all molecular biomarkers, which would effectively leap over cytology for either a primary screen or a triage if the entire assessment could be done assessing for HPV and a molecular marker. Another advanced technology that the National Cancer Institute has championed is using a mobile smartphone with the camera that's in there and artificial intelligence for an algorithm and communicating back and forth on the cloud, because it may be possible to assess the cervix with that technique. And finally, under treatment, we know that if you have to have a nitrous tank or electricity, that's a barrier. So the introduction of cold coagulation, which can run on a battery or solar power, has been instrumental in treatment in low and middle income countries. And also the ability to make decisions to see and treat rather than losing track of somebody or requiring them to come back. So all of those advances have been important, and BD's been supporting both the American Cancer Society and societies and organizations in Europe to try and help develop new technologies to eliminate cervical cancer.
Great. Thanks so much, Jeff. So I think one of the points that was brought up really by all of you was, I think you all alluded to this and understanding in various ways, knowing that HPV-35 may be particularly important in sub-Saharan Africa, the utilization of self-sampling in places where provider-initiated sampling is difficult, the reliance on the gene expert systems that were already in place for CML diagnostics. And I think, perhaps the point is that so much of getting these technologies out into the communities that need them really relies on an understanding of the local context. And I think that's often overlooked by, has been historically often overlooked, perhaps by the technology development community. So I'd love to get your thoughts on, how we do this better. That is, start with the end user in mind and the target communities in mind, right from the beginning, and truly co-create these technologies, co-design them with their involvement and with substantial local buy-in. Jeff, maybe we'll start with you here, if that's okay.
Yeah, thanks. One of our mottos in medical affairs is there's a patient at the start of everything we do. So the first thing is go to the place and listen and understand what the challenges are in that location, both for patients and for providers, in order to make an assessment and to make sure that the solution that's being offered is fit for purpose for the location. But also it's important to be able to have continuous ongoing training and service for whatever types of technology may be offered. I also think that when we're innovating, we have a tendency to innovate first and price later. And when we're looking at low and middle income countries, we need to start with a price point in mind and try and create and innovate within the limitations of what can be afforded in the specific country or region.
Thanks, Jeff. Deo, maybe we'll circle back to you and get your thoughts on how we can ensure that end users and target communities are involved early on in the development of new technologies.
Yeah, thank you. So absolutely, I agree with what's been previously said. I think it is quite important to have really collaborative engagements with places that are going to be using this technology. But certainly having the patient in mind, but also getting buy-in and input from the clinicians as well as policymakers at these places. I think there's certainly working in a collaborative way many times might not necessarily be fast, but sort of understanding the balance between really getting the appropriate buy-in from the get-go, being quite transparent, say, for example, with memoranda of understanding, as well as really having an iterative process such that once something is developed, it is tested, data is collected real time in a way that really does engage the local places. I think those are some things that are quite key. Another thing which has been mentioned previously is sort of the thought of having non-siloed systems. So the example of GeneXpert as a system that works across multiple platforms, such that there might already be local expertise in this type of technology, but being able to utilize that local expertise in a way that is cross-cutting, not just within cancer, but cross-cutting amongst several diseases as well. So I think those are some key things.
Thanks, Dale. I want to give Pat a chance to chime in. Do you think there are, how can we appropriately contextualize new technologies and do that earlier in their development?
Yeah, thank you. I agree with both Jeff and Dale on what they talked about. On the issue of pricing, one of the biggest challenges that we have with the use of the GeneXpert technology is that the reagents are still unaffordable, even with a preferential pricing. So that, that's a really big issue. And then, as Dale was talking about silos, I'll just share an anecdote. Some years ago, we went to one of the sites where we have our program, and we realized that physicians still could not properly diagnose CML, and they were actually having their physicians travel back and forth to the U.S. with blood in their, the little vials of blood in their pocket to do this diagnosis. So we got really excited and told them that we would facilitate access to a GeneXpert, and we would put a GeneXpert in the lab, and then when we send the official letter saying that we wanted to donate a GeneXpert to this lab, we received a letter from the lab telling us that they were so sorry, but they could not accept. And we were very, very confused and asked them why. And the reason that they gave us was that they did not have a floor space for this machine, because they already had 6 GeneXpert machines. The Gates Foundation was giving them 2, the CDC was giving them 2, and somebody else was giving them 2, and they didn't have place for our machine. And that was something that I had not understood, that sometimes as donors, we don't realize, and when we create these MOUs and these agreements, and I understand why we say, well, you can only use this for this program, that we create these silos. And I think we have a responsibility to think beyond, our own little program before we put this machine. So we have to be really careful as we introduce the technology to make sure that we understand, as Deo says, the context of that institution, and that we all can sort of work together. And I see Jeff wants to chime in as well. Yes?
Yeah, I'm appreciating what you said, Pat, because I think we have to see ourselves sometimes as disruptive, because we're asking to introduce some wonderful new program for diagnosis or treatment that's going to help, but it's going to disrupt or interfere with what the healthcare workers are already doing. So that's just one of the many things that we have to appreciate. I'm also reminded that there's a saying, guidelines are global, but application is local. And the other thing that's local is politics, and it's important to understand all the factors and predispositions about introducing a program or what seems to be a great idea, and in order to get everybody who's an influencer on board with the program and solve the problems like the one you mentioned, which is who's going to look after the instrument, who's going to look after the results, who's going to look after the patients.
Yeah, that's a great point, Jeff. I think as all of you were speaking, I was thinking, I think we're often so focused on trying to have the technology development go as fast as it can. And I think Deo spoke to not having the technology siloed. There's no reason we really couldn't think about stakeholder engagement the same way, right? I mean, that process doesn't fundamentally need to be siloed. And if you had a comprehensive understanding of the local context, that theoretically could be applied to, any new program or intervention and not, require inordinate delays. I think we think of that as a very cumbersome process. It's going to slow down progress, but I think it's because we're fundamentally thinking about it quite differently from the way we think about the technology development. And I'm not sure that that's always warranted or necessary even. So a couple of questions have started to come in through the chat, and I do want to try to address those. The first is, what are the critical success factors that have enabled technologies to increase equity, cancer health equity, and really meet end users at the point of care or at the point of need? Deo, do you want to start us off on thinking about that one?
Thank you. So just to follow up on one of the points you were just making, I think sort of highlights the real importance of having like a national cancer control plan, and having substantial input from different elements within the community, the society, the healthcare system in making that national cancer control plan, which will also include elements of what is sort of the next step, what are the grand plans for the country, what are the grand plans for the cancer community within the country. To your point, to the question that you were specifically asking, I think it is quite important to incorporate principles of implementation research into rolling out these technologies. So specific elements like how do you sort of adapt things in a way that does really fit that specific context. So, one technology can be used or sort of rolled out in a variety of different ways depending on what is happening at that specific place. So, how many people do they have, say, for example, in the lab? How much time does it take for something to be done? How many reagents does it take? So all of those things might seem like little minutiae, but are absolutely crucial in the success of something that might seem like a fantastic technology, or in the way that technology gets adapted to really fit the local context. So I think elements around rigorous adaptation and measurement, I think are quite key.
Thanks, Pat. Do you want to add anything there about, in addition to what Deo has said about critical success factors for implementing a new technology such that it increases equity and meets the end users where it's needed?
Yeah, I mean, I think in general we have to fight against our preconceived ideas as sort of as donors of what the sites and the implementing institutions need, and really listen to our implementing partners on the ground. And I think that that's sort of easier said than done, because, you know, in paper, everything looks so easy and simple and logical. And you have to really trying to understand what happens on the ground and work together to sort of overcome the challenges. And I mean, that seems like a very simple solution, but it's I think it's harder to do than identifying which things are real on the ground and which things can be overcome. I feel that, you know, if we can always keep that in the top of our mind, then that, you know, we can move a lot faster than otherwise.
Great. Pat, anything to add? I think we've heard rigorous adaptation from Deo and, you know, really listening despite all its challenges from Pat. Do you have any other critical success factors, Jeff, that you would want to recommend to the group and to those
I
listening?
would say three: time, money, and outcomes. So that the two most precious commodities might be time and money. So if your new technology will save time and save money, it's probably going to be popular. But actually having evidence of improved outcomes is essential, and you might be able to get a slightly more expensive, slightly more time-consuming solution in if it really has dramatically better outcomes. But time and money are short, and we need to find ways to bring solutions that are affordable and efficient.
Great. I want to follow from the discussion that we've just been having. I think, Deo, you were so right to raise, you know, this issue of how many lab staff are in the lab and are the reagents present, you know, all of these minutiae that, of course, are essential to, you know, the successful implementation of any new program or technology. So I want to ask all of you what strategies you've employed to ensure that you can have adequate supply chains for consumables and disposables, and that the new technologies are maintained and repaired in the LMIC health systems where they're deployed. Pat, maybe we could start with you here. How have you all done this successfully?
Yeah, I mean, for us, it has been critical to actually track the number of patients and how many patients need access to the technology, because that allows us to plan, forecast, and make sure that we can, you know, deliver the testing that patients need when they need it. I think also, obviously, supply chains are very, very complicated, and especially in the time of COVID, this hasn't gotten easier. One of the things specific to the GeneXpert, one of the challenges we've run into is that because this technology is sort of cuts across multiple diseases, and especially because now they have a COVID test, that we have run into manufacturing issues and not having enough manufacturing power to give us all the kits that we need. And then, of course, importation, shelf life, everything has been more complicated than before. But, you know, for us, like Jeff said, I really liked the comment that we need to focus on outcomes. For us, it's, you know, subsidizing some of the technology, the tests, and being committed to make sure that we're, you know, maintaining the equipment together with the sites has been very important, and really focusing on what does the patient need, and can we make sure the patient has what they need when they need it.
Jeff, why don't you chime in here too? Kind of how have you maintained supply chains and ensured that new technologies were, you know, kept operating, et cetera, you know, dealt with all of these very critically important minutia as critically important minutia, as I think Deo told us several minutes ago.
We've partnered with support of organizations like PEPFAR, USAID, and the Fleming Fund. And so we provide both the technology and the training in countries in Africa and Asia. We also work through the local or regional distributor because they're highly available. There are certain parts and pieces of equipment that are likely to need replacement, so we're able to put those kind of in a cupboard close at hand because of the shipping times involved with some of the countries, depending on where things are manufactured. So trying to bring some of the commonly used materials close to hand and working with the local regional people. And then, of course, the advent of the internet's been extremely helpful in terms of video communication, and you can have an expert thousands of miles away who's able to see and correct the problem with the help of the person whose hands are on site.
Thanks, Jeff. Deo, do you want to add anything here about maintaining supply chains, keeping equipment operational?
Yeah. So I'll add a couple of things. Going back to the idea of having things that are more integrated into existing systems, I think having new systems getting integrated into, or the needs for new systems getting integrated, say, into the routine supply chain system of the Ministry of Health, many times can ensure long-term sustainability, as opposed to just one-time events or one-time utilization. I think another thing along these lines, which is not quite supply chain, but the presence of having local experts or local repairers or technicians to repair machines when they break, it is more likely to have that type of expertise if it's a machine that is more commonly used, as opposed to just the one machine that just does one specific thing. So sort of going back to the point of having cross-cutting platforms that the local teams already have some existing expertise in. The last thing I was going to add is, which Jeff sort of alluded to, is having regional collaborations or regional hubs. So countries within the same region, say for example the East Africa region, can have things that they're able to do. So even if not each country has their own technician or not each country has something, there can be a regional hub that can serve that region. So those are some thoughts.
Yeah, those are great thoughts. I mean, just to add one additional comment, I think to take this even further, right? Eventually, the manufacture can occur within these countries. I think there's not. I think we often pretend as if that can't happen. And one nice outcome of COVID, hopefully, will be to try to make some of these sophisticated advanced technologies, the manufacturing capacity actually available in sub-Saharan Africa. And obviously, there's a lot of discussion ongoing around mRNA vaccination and other things that I think would be a great outcome for the pandemic if we're able to achieve that. So I think we're starting to get close to time. Deo, I wanted to come back to you. Are there other kind of thoughts? I don't want to run over because I know that the summit schedule is quite packed. So maybe want to revisit and give everyone a chance to share anything that we didn't capture during this discussion so far, or give you a chance to kind of make any other comments that you haven't had a chance already. Maybe with Deo, we could start with you.
Yeah, I think ultimately the importance of really engaging with local partners, so the people who are going to be utilizing this technology on the ground, the people who are going to be caring for the patients, the local policymakers, and really having those folks see themselves as actual real partners, like equitable partners in collaborations. I think that certainly goes a long way. Just the concept of constant measurement. I think sometimes it is challenging, but making sure that there is measurement of how things are doing. To Jeff's initial point of sort of keeping outcome as a essential sort of like guiding post.
Thanks so much, Deo. Jeff, anything that you had wanted to raise that we haven't had a chance to touch on to this point in the discussion?
Yes, thanks. Deo reminded me of redundancy. So in terms of diagnostics, you could have 6 small instruments all doing the same thing, or one big instrument that can do 6 times. If one of the small instruments stops working, you can keep going with 5/6 of your capacity. But if the one instrument stops working, you could be out of functioning for some time. So one approach is to use smaller instruments with redundancy. BD has begun to build redundancy into our instruments so that they kind of have twin functioning, and if one part isn't working, at least the instrument will keep running at half speed until a service technician can get there with the necessary part.
Yeah, I mean, thank you for raising that. I think that's something we failed to touch on already and is obviously critically important for making some of these systems function effectively. Pat, anything that you want to raise based on your experience at the Max Foundation that we haven't had a chance to touch on to this point in the conversation?
Yeah, I feel that the one thing we perhaps didn't speak enough is the need for education and information, especially when we're introducing new technology. And in our experience, especially with the gene expert, that functions exactly like Jeff was saying, where each of the modules actually is independent from each other. So if a module, something happens to a module, you can still be using this instrument and all the other modules. But the other side of that is that you can be running, let's say, a TB test in one of the modules and a BCR-ABL test in another one. They are completely closed systems, and it has been really difficult for lab technicians and lab people to actually understand that there's no possibility of cross-contamination. And a lot of the reluctance to use the technology is that it just does not compute in people's minds that that could actually happen. And so we have had to do a lot more of information and education, which these days, we can do virtually. So that's one of the sort of the plus sides of this whole new COVID world. But I do think that access to good education and really working with the labs to make sure that they understand the technology is really important.
Yeah, thanks all. I mean, those are, I think, some really wonderful closing thoughts. I think we probably need to start wrapping this up. I mean, I think, I really want to thank all of you for participating and for UICC for inviting us to have this discussion about technology development and equity. I think, I'll just speak for myself. I think you all have reinforced a lot of the things that we are thinking about at the NCI as we develop our own technology and implementation science portfolios about the need for end user co-design and implementation research with rigorous adaptation and adequate stakeholder engagement at all phases of the research. So I think it's certainly been validating for us to hear so many of the things that we're trying to think deeply about going forward, reinforced by, I think, the comments that have been made by, this really wonderful panel discussion that we've had this morning. So I think with that, we've got a little bit more than a minute left, but probably not enough time to substantively address any other issues. So thanks again. We'll look forward to continuing this conversation, in the online networking possibilities afforded through the Summit platform. But I think we'll close it there and just want to thank everyone for tuning in. And thanks again to Deo and to Jeff and to Pat for joining me for this conversation and sharing so much of your immensely valuable experience on this topic.
Thanks to everybody.
Thank you. Thank you. This is good.
Thank you so much.
Bye, everyone.